Hello, my name is Scott Lakin. I'm the in-house clinical coordinator from Indiana Donor Network assigned to Eskenazi Hospital full-time. I'm sorry that I can't be with you today in person, but I wanted to share with you some important information so that you and I can work together in the best interest of our patients who are looking for organ and tissue. So our objectives today is for you to better understand how organ, tissue, and eye donation happens, recognize when it's time for you to make an organ or tissue referral, appreciate that this is a collaborative process, meaning you and I and the doctor, you and I and the doctor and the respiratory therapist. Identify what a planned approach is. None of us like to work from the seat of our pants, so we like to have a planned process. And then define your role, because you are one of the most important pieces of the organ and tissue donation process. In about the 1980s, the Centers for Medicare and Medicaid decided that it was less expensive to pay for kidney transplantation than it was to keep patients on dialysis and pay for the hospitalizations. So really in the 1980s is when the federal government started becoming a payer in the donation process. And so the Centers for Medicare and Medicaid, CMS, have a regulation that says if you're a hospital that takes CMS money, and that's really everybody, then you have to play in the process and you have to have a contract with an organ procurement organization. In the state of Indiana, Indiana Donor Network is the organ procurement organization. There are only two places in the state of Indiana where we are not that organ procurement organization, and that's around the Cincinnati area and around the Chicago area. We have contracts with 168 hospitals in the state of Indiana. Those contracts don't have any money attached. The contract just says that we'll both play together and we'll work towards having organ and tissue donation. But before I go into all of the things that you need to know about organ and tissue donation, I want to talk to you a little bit about Indiana Donor Network. And really, there's a lot to the organization. And the first thing that's on this slide is community education. We have an entire team of people who, especially pre-COVID, would go to county fairs, the state fair, high schools, church groups, anywhere in the state of Indiana, where they could go out and talk about how important tissue and organ donation was. Now we do a lot of that via technology because of the COVID. However, we're still making a footprint, especially in the racing, motor racing division. We also have donor and family support. We have someone who is at every donor hospital, and I'm assigned to you at Eskenazi. And then transplant centers, so that's on the far end of the process. We have people like me who work specifically with those transplant doctors to make sure that we're providing them with the type of organs in the specific condition that they need them. These are the transplant centers in Indiana. Most importantly in Indianapolis would be Indiana University Hospital, Methodist Hospital, Riley, and St. Vincent. So now the question is why? This slide is meant to represent what it feels like today when you drive anywhere around Indianapolis. You know you're trying to get to your destination, yet you have to wait, and you have to wait, and you have to wait. And really, that's how a recipient of an organ or tissue feels waiting for someone to donate. So the reality is that today, 20 people in the United States will die waiting for a transplant. This slide represents the challenge we have for organ donation in Indiana. At the top or base of the pyramid, there are almost 7 million Hoosiers, and 60% of those are registered organ donors. To be an organ donor, you have to die in the hospital, and of the 21,000, there were 10,300 actual organ referrals. There were 382 eligible donors. 252 were actual organ donors. This number 300 represents the amount of cases where organ referrals were not called in throughout the state of Indiana. So what happens if for all of those 300 referrals, even 10% of those 30 were able to donate, and they were able to donate 3 organs a person? That's almost 100 additional organs that we could have gotten last year if someone had called us. First person authorization means that you have on your driver's license or in your living will said, yes, I want to be a donor. And first person authorization falls under the International Gift Act, which says, if in writing I say to you, I'm going to give you something after I die, and I die, no one can change that. It's a binding contract. The only time that this can be changed is if you're a 16-year-old in the state of Indiana, you get your driver's license and you say, yes, you want to be a donor. The parents of that child can change that up to the time that they turn 18. At 18, that's legally binding. So let's talk about the organ referral process. To be an organ donor, someone has to have a beating heart and they have to be on a ventilator. Then they have to be determined that their organs are suitable for donation. And then we follow up with that patient daily. We try to make sure that every patient that has a withdrawal of medical therapy is also evaluated. And anytime a family member mentions organ donation, those are all valid triggers. So in organ donation, there are 2 types of donation. 90% of those are brain death. Brain death is very cut and dry. It's very black and white. And the one thing I'll say over and over again is get the policy and follow your policy. Brain death happens due to drug overdose, maybe where there's an anoxic injury, smoke inhalation, a stroke, head trauma, gunshot. All of those are indicators or causes of brain death. Brain death is not a coma. People don't wake up out of brain death. Brain death is defined as irreversible destructive brain and brainstem injury. Physicians use several tools to determine brain death in the state of Indiana. One of them is a brain flow study. And this slide indicates a patient that has brain flow and a patient who has no brain flow. But before that test is ordered, providers do a clinical exam that can include cold calorics. Cold calorics is an exam of the brainstem where the patient's eyes, the eyelids are lifted, and ice cold water in a syringe is pushed into an ear canal. And if there is still connectivity of the brainstem, the patient's eyes will automatically reflect over to that side. And the normal neuro tests that are done. So in the process, following your policy, there'll be a clinical exam, there can be an apnea test, and then some sort of confirmatory test. Once the physician writes that the patient has failed those exams, that means the patient is brain dead. And in the state of Indiana, brain death is legal death. In your hospital policy, there's a checklist. Please work with the physician to make sure that the documentation is clear, and understand in Eskenazi's EPIC system, there is a template for those physicians to follow that makes it easier for them. And hopefully before all of that testing is done, we will have been referred, the patient will have been referred, and Indiana Donor Network representatives will be on site. The second type of organ donation is 10% of all of the donations that we currently do, and that's donation after circulatory death. We also call that DCD. These patients have not fully herniated. They have not suffered a total anoxic injury, so they have some brainstem activity, but these folks will not have a positive quality of life moving forward. They may be the patient that has a trach, and then they have a PEG, and they end up in a vegetative type state in a nursing home. A lot of times we'll hear on the DCD cases, we'll hear families say, well, Uncle George wouldn't want to live this way. And so they want to withdraw care. And this is the opportunity that we have then for donation after circulatory death. If we back up to brain death donation, these patients are at some point soon after they're declared brain dead, those folks are transported to our office on Guyan Road, where we have an ICU and 2 OR suites where we can take care of them, free up the ICU bed at the hospital, and we can do the procurement here and not in an OR at Eskenazi. A DCD, on the other hand, is done in the hospital because the patient has to pass within 90 minutes of extubation so that the organs will not be hypoxic and they will have had circulation during that time. If the patient passes before 90 minutes, the transplant team comes in and the organs are procured there in the hospital. If for some reason that patient lives longer than 90 minutes, then that patient is brought back upstairs, placed in hospice, and allowed to have their family with them as they pass. Reviewing the difference between brain death donation and DCD donation, the brain death donation, the physician has declared the patient legally dead, and the patient is then the custody of the patient is handed to Indiana Donor Network. The patient's transported to our headquarters for further care. With the DCD patient, there has to be a conversation between the primary care physician and our medical director to say, we believe this patient could pass within 90 minutes not being on the vent. And if that's the case, then they could be a donor hero. Those people then are taken to the OR. They have 90 minutes. And if they don't pass in that 90 minutes, they're then put in palliative care. One of the other questions that I get a lot is, what about talking about donation to my families? We're asking you not to mention organ and tissue donation. If you or a provider mentions or talks about organ donation prior to Indiana Donor Network coming on site, we have an 18% chance of getting a yes. On the other hand, if you don't mention or talk about organ donation, we have a 78% chance of getting a yes. So questions that I normally receive from nurses include, well, what happens if somebody comes up to me and says, tell me all about organ donation? One of the things that you can say is, in your own words, we work with a group of people that are the experts in organ and tissue donation, and I would like to have them come and talk with you. And that gets you out of the middle, and it provides us an opportunity to come on site and talk to them using the right words at the right time in hopes that we would get a positive yes for donation. So in organ donation, there are 8 organs that can be donated. These are some goals that we try to keep the patient's chemistry in during the time between the time they're declared dead and the time that we go to the OR. And then I want to talk about the donor management process. So in a minute, we're going to talk about how you call in a referral and how that starts the entire process. When you call in a referral, someone from hospital services like myself will call you and come into the hospital and talk with you, talk with the provider, talk with respiratory therapy, look in the electronic medical record, and assess the patient. When it's time, or if it's time that we get permission for organ donation, then a member of our family services team, who are social worker-driven folks, will come and work with the family and support the family. When we get authorization to move forward, we have a team of folks called the organ recovery coordinators who will come to the hospital and work with you to keep the patient stable and to keep the chemistries of the patient where we need them to be. They will do some blood work, maybe ask for a cardiac cath or a specific radiology exam, and that's because we're allocating the organs throughout most of the country, and specific locations or transplant doctors will want a specific test done on an organ prior to saying yes, they'd like that. Allocation can take anywhere from 18 to 48 hours. Sometimes that seems like it's a long time, and it really does seem that way. However, we want to make sure that we get the right organ to the right patient. Sometimes weather can play a factor in all of this, or having the right staff at the right place at the right time. And timing is really important. If we have a team that's coming from Cleveland and they have snow, that may delay them getting here. So it's not an exact science, especially with timing. We try to give families and staff a ballpark, but that's not always easy to do. Organs that have been recovered last outside of the body. Different organs last shorter or longer hours. And as you can see here, hearts and lungs last somewhere between 4 to 6 hours. Those will be allocated closer to Indianapolis, whereas kidneys can go for 72 hours. The device in this slide is a life pack, and inside that, where you see the netting, is an actual kidney that's being perfused. So sometimes we can take kidneys, perfuse them for a couple of days, and then reallocate them. Organ donation, you have to have a beating heart and the patient has to be ventilated. On the other hand, tissue is all done after cardiac time of death. That's what CTOD stands for. Those patients are brought to our location for recovery, and we have up to 24 hours to recover that tissue. These are the different types of tissue that can be recovered: corneas, skin, valves, bone, all done here at our location. And these are just some locations of places where our tissue has gone. Another type of tissue recovery is called a vascularized composite allograft, or a VCA. This patient had an entire face transplant. So on the far left is David, who was riding his bike in Brooklyn, was hit by a car, had severe brain injury, and was brain dead. In the middle is Pat, who was a firefighter in 2001, had an accident in the fire, and was burned over 90% of his body. And the next slide shows Pat 4 years after the accident, after 70 reconstructive surgeries. His quality of life was not where he wanted it to be, and so he and a team searched for someone who was willing to give them an entire face donation. And they found that in David Rodenberg's family. The picture then on the far right is what Pat looked like 3 years after that surgery. VCAs are not done very often, but they are done in the United States. And now the most important part of my presentation, which is your role in making sure that we at Indiana Donor Network understand and are aware of patients that have high potential. So your role as a nurse includes calling us anytime the patient meets a clinical trigger. One of the most common clinical triggers is if the patient is on a ventilator and they have a Glasgow of 5, 4, or 3, regardless of sedation. So if the patient had a Glasgow of 10, but needed to be chemically paralyzed, and now they're on the vent and their Glasgow's of 3, that patient meets the criteria and should be called within the first hour. Another trigger is the family talking about donation. Another trigger is the family is going to withdraw care. And the last trigger is using your nursing judgment. The patient has a Glasgow of 7, is on the vent, but just has been getting worse and worse all day long. Give us a call and let's open a referral. Follow your hospital policy. Regardless whether it's brain death testing or DCD, every hospital has a policy. Please be familiar with that policy. And know that we're working with you. These patients don't become our patients, as an Indiana Donor Network. They're your patient and my patient to take care of. Timing matters. We want you to give us a call for both organ and tissue referral within the first hour. and why. The patient can become unstable. There can be OR availability issues. There can be weather issues. All of those things can affect our ability to properly assess the patient's ability to donate. You don't have to be the one to call. If you're busy with a patient, you can ask a colleague to call the 1-800 number, and they can call it in because we're going to ask very few pieces of information, and all of those can come from the electronic medical record. On the recipient side, let's talk about Cleveland again. They have to have their OR ready. They have to have their patient prepped. They have to have everybody in place there. So it is a big timing dance. Your calling us within the first hour is really, really important. And that is why we have TXJet. Indiana Donor Network owns and operates 3 Cessna Citations that are available at the airport in Indianapolis 24 hours a day so that we can transport medical teams or organs and tissue. Once there's been a referral, it's important that you provide us with updates, such as changes in condition, plans to do brain testing, end-of-life discussions, or the time of death for tissue. And so in summary, your role is to provide the best possible care possible, and that's what you do every day. And when the patient meets triggers, that you would call us within that hour. You will notify us of changes in the patient condition, and we will huddle with you to make sure that all of us are on the same page as this case progresses, and that you will work collaboratively with us and the donation team to keep the patient comfortable and help them leave a heroic legacy. The things you need to know. Call us whenever the clinical trigger is met. Mainly, a Glasgow Coma Scale of 5, 4, or 3, and the patient's on a ventilator regardless of sedation. Anytime there's brain death declaration, especially by your hospital policy, please don't mention donation. Call us and we'll have someone come and do that for you. Your role in tissue donation is to call us every time any patient dies, at least up to an hour of cardiac time of death. That's 100% of the cases. Do not release the patient that's passed away to a funeral home, because once the funeral home starts their process, we can't do donation. And try to obtain multiple phone numbers if possible, because sometimes we'll call a particular key family member and they may not answer the phone. I wanted to let you know that we also provide support to the family. Our family advocates are grief counselors. They also offer to every donor and potential donor family a 13-month bereavement process. We do hospital honor walks at Eskenazi. We raise a flag at Eskenazi, and when the case is finished, we give that flag to the family. There are memory-making items such as the ones on the screen to include the heartbeat bear that you see in the middle. If the family wants one or more of the heartbeat bears, we take a Doppler and record 30 seconds of the patient's heartbeat. It goes on a recorder that goes in the back of the bear, and so every time they squeeze the bear, they have 30 seconds of their loved one's heartbeat. This is a picture of our Donate Life Indiana flag during a case. That's the flagpole out front of the ER facing the VA. So if you ever come in on St. Margaret's Drive off of 10th Street and you see that flag flying, you'll know that there's a case going. I've tried to give you every piece of information possible, but if you have other questions, ask any of your clinical managers and they know how to get a hold of me, or contact me at the email address. Thank you for your time and thank you for what you do.